This is a case of laparoscopic cholecystectomy through three port. So it is a three-port laparoscopic cholecystectomy. The patient is suffering from acute exacerbations of chronic calculous cholecystitis, having type 2 diabetes mellitus for last 16 years and having ischemic heart disease with hypertension. And here the most challenging is the three-port cholecystectomy, that is the two 10 mm port and one 5 mm mid clavicular port, and through this we have performed our total laparoscopic cholecystectomy, and the pressure remains little below the pneumoperitoneum. The pressure is 9 and the flow rate is 9. Generally we prefer to give pneumoperitoneum pressure 15, but due to this ischemic heart disease and diabetic with hypertension, we prefer to keep it low. You can see the 10 mm port, epigastric port, and it is the 5 mm port which are going to be inserted through the mid clavicular line on the right side. 10 mm umbilical port, so two 10 mm and one 5 mm port, and it is a three port cholecystectomy. And here we use the bipolar and the bowel grasper only for proper hemostasis and proper safe surgery. You can see the distended gallbladder and bipolar forceps is introduced through the 10 mm epigastric port. The bowel holding gasper has been grasped. First step is the additional lysis. You can see the additions of the momentum with the fundus of the gallbladder. So gentle traction, and with the help of the bipolar we are gently separated it. Bipolar forceps is very helpful and maintaining the proper hemostasis, as well as no advertent injury and no perforations of the gallbladder happen, that sometimes may happen with the unipolar. And it is an small birds and maintaining the hemostasis and reduction of the fumes also we can see. Now the first step is the additional lysis is going on. We are generally changing our traction. More traction has been applied, and we are going towards the Hartmann's. Now the additional lysis is going on. Small birds is the main thing, and the diathermy bipolar has been maintained at 25. The coagulations remains at 25, not more than that. You can see again we are changing our traction. Now generally the Hartmann is visible, and you can see the rubeus sulcus. There is small bleeding, so we have to control it with the bipolar. You can see the rubeus sulcus remaining just beneath this instrument. If it is a learning curve for the three-port laparoscopic cholecystectomy is the main thing, so be patient, and you have to select the patients accordingly. And in my previous video I told you that I will the three-port cholecystectomy surgery will be uploaded shortly. So now it has been totally uploaded in the YouTube channel. You can see here little gentleness and patience should be maintained. The Hartmann is now visible. Now we are again changing our traction, and the addition near the Hartmann, the fat addition, small birds has been applied, and you can see it. And now our target is to locate the cystic duct, and you can now see the medial jaw of the bipolar forceps. There is the presence of the lymph node of the Lund, so the cystic artery will remain here somewhere else in this area. So now I am separating the cystic duct from the cystic artery, and for this purpose I am just apply some pressure, some traction, counter traction, and try to clear the view due to this fat planes that are adhered with it due to the acute exacerbations of this chronic calculus cholestatis. On the right side, you can see the cystic artery is hidden just beneath this fat plane. Now the traction has been changed again, and the Maryland forceps we are now going to introduce after some kind of separation from the site. And you can see the small adhesion that has been uh, separated millimeter by millimeter near the calots. Now we are going to introduce the Maryland forceps. The sharp tip is very much helpful here to separate the cystic artery from the cystic duct. Now you can separate, now I am separating the cystic duct from the cystic artery. Yes, you can see that is the only cystic duct that has been separated out from the cystic artery, and the critical view of safety Storsberg has been achieved, and cystic artery is going to drain to the common hepatic duct. You can see cystic duct is going to be drained and communicate with the common hepatic duct to form the common bile duct. Now we are going to apply the 300 titanium Liga clip at the cystic duct. Sometimes it is very difficult to achieve the critical view of safety in 3-port laparoscopic cholecystectomy only through the bipolar forceps. So it is the experience of the surgeon, but gradually when you operate, the critical view of safety will be evident. I am trying to here to see, you can see the cystic arteries nicely and the cystic duct also. Again I am applying the another 300 Liga clip, and you can see the beautifully the cystic artery and the cystic duct separately. When you can see this, just retracting this fat plane, the cystic artery is evident. So two proximal stump clip and one distal stump clip, 300 titanium Liga clip has been applied, and now you can see clearly the cystic artery. So it is the critical view of safety has been achieved. Now we are going to apply the two clips at the cystic artery. Some surgeons prefer not to apply any clip in the cystic artery, only they can coagulate it with the bipolar, but I usually prefer for double secure of the cystic artery, because it is the life threatening issue may happen later on. So after proper applications of the clips, 2 at the cystic artery and 3 at the cystic duct, now I am going to coagulate the distalmost part of the cystic artery, that is towards the gallbladder, with the help of the bipolar forceps. So here with the bipolar, the cystic artery bleeding can be controlled, number 1, and number 2, due to the presence of the 2 Liga clip proximal to the stump, it is more securance for the patient for any life-threatening complications regarding the hemostasis. Now small buds has been applied over the distal part of the cystic artery stump towards the gallbladder, and that has been separated, not to create too much traction or pulling it out, just make it sure that after proper bursts and coagulation with the bipolar, you have to cut it, because in this bipolar both the coagulation and the cutting option is there. So after proper coagulating it, then you can use the cutting for proper cutting of the tissue. So at the same time you can hemostasize it as well as coagulate it and cut it, and cut as you go. Then I am using the scissor for cutting of the cystic artery, a cystic duct, in between the proximal two stump, two clips, and distally one clip. Now I am going to use the bipolar for additional lysis. You can see beautifully and nicely that the cystic artery remaining proximal, the stump is proximal and no bleeding, and the tissue that has been desiccated with the bipolar forceps, and small birds is used, and it can be gently separated from the liver bed without any much difficulty if traction counter traction is applied properly. So you can see the how the beautiful we can do the three-port cholecystectomy. There is some tractional issue may happen, but make it a patience, and it is very much helpful for these patients also, because due to this procedure the conventional it is very much effective as compared to the conventional four-port cholecystectomy. And if you will master enough in this three ports, then you never ever do the four-port cholecystectomy unless otherwise indicated. Sometimes dense additions may be there, but I generally prefer to do this with the bipolar, and it helps proper hemostasis, and you can see the no bleeding from the liver bed itself. Only the traction and the counter traction matters, and the gallbladder is distended here. The small birds is the main and key thing for proper embryonic plane to be separated and coagulating the intervening bridging vessels, and no bleeding at all from the liver bed you can see. And that is the beauty of the three-port cholecystectomy. It takes only around half an hour to be completed if you do it properly. And due to this bipolar, the no bleeding from the liver bed as well as no advertent injury of the liver sinus may happen. That may happen with the monopolar or bipolar monopolar diathermy hook, or sometimes the hook may touch the gallbladder wall, leading to the spillage of the bile, and stones sometimes happen. But the bipolar is so safe that you may just coagulate the cystic artery, and even you may not apply clip at all. Though I prefer to use the clip, you can see beautifully the lumen of the cystic duct which is remaining proximally. And now the gallbladder has to be extracted out through the umbilical port, and you can see beautifully the midclavicular port that is the 5 mm. It is the umbilical port, and the epigastric port. Through the epigastric port we are introducing now our telescope, and through the umbilical port the gallbladder extraction forceps or crocodile forceps has been introduced. The clip has to be properly sealed within the instrument so that it will not stuck into the port. Here it is just stucking, so I just leave it and reapply the instrument crocodile forceps. And now the again I am just take it out, and now the gallbladder has been extracted out. Small bile is coming from the opening, but there will be no issue. We will thoroughly clean this area following the peritoneal lavage or abdominal toileting. We routinely perform it. Now the gallbladder has been extracting and the intraluminal bile has been sucked out with the sucker. The stone has been impacted within it. So after opening the distal part, yes, it has been sucked out all the bile, and you can see the stone that has been popping out from the wall. Now the gallbladder has been taken out. After small dilating the path, you may not dilate the path, you may crush it, but sometimes the patient relative may want to see the exact size of the stone, so sometimes you have to bring it out as intact. So that's why I'm struggling to taking it out, maintaining the shape and size of the stone intact, not to crush it. Yes, it has been removed at all. The port site has been thoroughly washed with the warm normal saline and the betadine solutions, and with the syringe I am also introducing the betadine within the intraluminal part and normal saline also, so that you can see the finger that is coming out, my index finger, left hand. Now you can see the only 3 port remaining outside. Now telescope has been reintroduced to the umbilical port, and thorough peritoneal toileting of the hepatorenal pouch of Morrison and the gallbladder fossa is initiated. It has been initiated, and now the warm saline lavage, it is the main thing after the entire surgery. And you can see the color is not bile stain or blood stain, and you can see the some gallbladder tissue, so it has been removed with the help of the bowel forceps. You can see the bile that was leaking here from the gallbladder has been washed with the normal saline. You may take the gallbladder through the endo bag also, no issue. Another tissue has been removed, and entire tissue with the gallbladder has been sent for histopathological examination to rule out malignancy or any tubercular changes, because you know the diabetes and the tuberculosis are remaining side by side in a single patient. So the thorough peritoneum wash from each and every side, I try to make the abdomen dry with the proper delineations of the area and the pockets, that is from the right iliac region, the pelvis. So I am trying to suck it out, all the toileted fluid that is remaining within this. If you make it dry, the patients will be happy, and post-operative recovery will be very good, as I don't prefer to give any drain intra-abdominally. But if you want to give any drain, then you may remain this fluid as is, because it will coming out from the drain. I don't prefer to give a drain here. And in a laparoscopic surgery, unless uh, indicated. You can see this. The lever bed has been properly making dry. Now the port has been out, 5 mm, 10 mm, and this is the camera port.